Emergency department discharge to care, telephone outreach, connect to aftercare and risk evaluation, improving patient care and systems-based practices. Emergency department utilization is rapidly growing nationwide, with psychiatric concerns constituting 4.45% of annual ED visits and representing significant costs. When compared to ED patients receiving outpatient referrals for medical conditions, ED patients receiving referrals for psychiatric care are more likely to reach an answering machine, to obtain an appointment greater than 2 weeks away, or be referred elsewhere for insurance reasons. There's a small body of literature demonstrating that follow-up contact from the ED can mitigate short-term safety risks, provide needed ongoing psychoeducation, and can keep the patient motivated to engage in outpatient treatment. The purpose of ED discharge to care is to provide a caring contact for patients discharged to home or a lower level of care after they have presented to the ED with psychiatric concerns. The follow-up contact focuses on the patient's aftercare and outpatient treatment arrangements, as well as any immediate safety concerns. The goal is to both enhance the quality of patient care and to decrease ED readmissions. This multidisciplinary approach to providing timely post-discharge follow-up for ED patients with psychiatric concerns should positively impact patient care and systems-based processes, including connection to outpatient resources, treatment retention, and decreased ED readmissions in an already overburdened acute care system. For our protocol, patients were seen by the embedded ED psychiatry service, either psychiatrist or psychiatry social worker, and agreed to post-discharge follow-up contact during the ED visit. Our dedicated ED psychiatric social worker called patients 48 to 72 hours post-discharge for a total of 3 attempts. Social worker asked protocolized questions regarding outpatient follow-up, medication status and adherence, and suicidal ideation via the PHQ-9 screening, question 9. For a positive suicide screen, further questions included access to lethal means, crisis resources, and if needed, welfare check was pursued. The ED psychiatry team evaluated a total of 711 patients from the time of launch on February 1st, 2021 to time of data analysis on September 10th, 2021, a total of 6.5 months. Of these patients, 400 were eligible and subsequently included in the ED discharge to care follow-up protocol. A total of 237 patients were ineligible for our follow-up protocol, with 96% of these patients being discharged to a higher level of care. Other reasons for ineligibility included patient in police custody, ED revisit, or curbside consult. Of the patients reached, 88% of them had either already scheduled, initiated contact, or verbalized intent to schedule an outpatient appointment. During follow-up contact, patients often express gratitude for both care received in the ED and during the post-discharge telephone contact. This impact is difficult to express quantitatively, but could drive treatment adherence and further lessen ED readmissions on an individual basis. Proposed future directions include multiple options. First, further investigation into 30-day readmission data could be directed toward the impact of patient housing status and satisfaction with housing arrangements, an important consideration to those who reside in group homes or community-based facilities. Additionally, further examination of the impact of chief complaint, primary diagnosis, or comorbid diagnoses during repeated presentations could provide additional context to readmission rates and guide further interventions. Of note, of the patients eligible for follow-up contact but the protocol was not followed, 60% of them did not have working phones. An alternative contact workflow should be considered for this sizable patient cohort. In conclusion, the ED Discharge to Care initiative aims to add to the limited evidence base to support continued integration of multidisciplinary psychiatry teams into medical care settings, in this case, the emergency department. As ED resources are progressively strained, there is a growing focus on addressing population health factors. Reducing barriers to accessing psychiatric care, bolstering quality and efficiency of safe psychiatric care, and optimizing resource distribution should be top priorities for psychiatrists working collaboratively in these settings. Thank you.